Hello, everyone. My name is Jonathan Flores, and today we're going to be talking about physician assisted death ethical issues. So, what exactly is physician assisted death or PAD? Well, it refers to the practice where a physician provides a potentially lethal medication to a terminally ill, suffering patient at his request that he can take or not at a time of his own choosing to end his life. It is also called physician assisted suicide, physician aid in dying, and patient administered hastened death. Physician-assisted suicide is legal in 9 U.S. states and the District of Columbia. These include California, Colorado, Hawaii, Maine, New Jersey, Oregon, Vermont, and Washington state. It is an option given to individuals in Montana and California via court decision. So there are some ethical issues within PAD. And here are some arguments in favor of it. The first one being patient autonomy, which means a patient should have the right to control the circumstances of his or her own death and to determine how much suffering is too much. The second one being mercy, which is if a patient's pain and suffering cannot be sufficiently relieved with state-of-the-art palliative care, then the physician has an obligation to do everything within his or her power to relieve that suffering, even to the point of hastening death if there are no realistic alternatives acceptable to the patient. The third is non-abandonment, the physician's obligation to his or her patient and family to see the dying process through and to be as responsible as possible outweigh other obligations and restrictions in these troubling circumstances. So there are also arguments that go against PAD. The first one is wrongness of killing. This means that purposefully helping a patient die is categorically wrong under any circumstance. Excellent palliative care does not include PAD. The second one is physician integrity. Physicians take a sacred oath never to knowingly harm a patient, and PAD would violate professional standards and undermine trust between physician and the patient. The third is risk of abuse. This means that allowing PAD poses too high of a risk to vulnerable patients. Their lives could eventually be ended against their own will, or when alternative approaches to relieve suffering might be expensive or the suffering difficult to treat. So I also have my own opinion when it comes to PAD. Based on my cultural and faith-based values, it is wrong to participate in any ending of a person's life. And anchored on my belief in afterlife, something like that could hasten their journey to a place of torment. I believe there is one giver of all life who is the only one that can give it or take it away. And I also truly stand with the state-of-the-art palliative care, which remains the standard of care for any end-of-life suffering. So what can we say about the future of PAD? Well, let's look at this. In 2003, Oregon was the only U.S. state authorizing PAD. And ever since, a total of 9 states have enacted laws to legalize PAD and euthanasia. The argument that PAD is a human right will become more acceptable as more states will legalize PAD throughout statuses or court rulings. From the Oregon state data presented in this slide, the number of PAD deaths will continue to increase as more people accept it. From 16 deaths in 1998 to 143 deaths in 2017, the number will continue to rise. Physicians need to be more prepared to operate in environments in which PAD becomes more common, even if they do not conduct them individually. Physicians play an integral role as gatekeeper in the process of PAD, as it is their job to write the lethal prescription. An article written by Jack Cohen in the New England Journal of Medicine in 1994 mentioned that 50% of physicians in Washington state supported PAD, while 39% believe that it is never justified. Hematologists and oncologists, who are more exposed to terminally ill patients, were the greatest opponents of PAD. Another article in the Journal of Medical Ethics in 2007 noted that physicians working with patients who had requested PAD were more supportive of legalization than those who had not worked with patients who requested PAD. Hospital Ethics Committee, or HEC, help with integration of social, cultural, and religious norms in the healthcare. It is the multidisciplinary team that helps patients, families, and clinicians address value disagreement in healthcare provision. HEC will help with personal decisions regarding PAD. HEC needs sufficient training on medical ethics so that they can offer guidance on different PAD ethical dilemmas. Although I lean more towards being against PAD, here are some of the policies that I would implement if PAD was to be approved in all states in the US. PAD should be made in writing. A person should be competent and conscious. The patient should be suffering from a serious incurable disorder that causes persistent, unbearable suffering. There should also be a discussion on treatment options, including palliative care. An independent second opinion should be considered. A report of the procedure should also be made to the authorities. This process should only be done by medical doctors. Nurses should not administer the injection, and it should not be at home to ensure that there is compliance. When the nurses administer the drug, it should be in the presence of the prescribing physician. This system of regulations and safeguards I truly believe that should be effective. And to conclude, here are the references that I used for this project. Thank you very much.